All right. Well, welcome back everyone to another wonderful dialogue with the Coronavirus Multispecies Reading Group. We are extending a huge welcome to our very gracious guests today. We have Dr. Ben Hegarty, Sandeep Nanwani, and Amalia Handayani, and I hope I pronounced those all correctly. I apologize if I did not. And please correct me. Thank you so much for joining us and for sharing your latest research with us. You have two pieces that were published in 2021, already an amazing feat in and of itself. And I just cannot wait to dig into this important research. So you've shared two pieces with us. This new article, Chasing Targets in a Pandemic, the Impact of COVID-19 on HIV Outreach Workers for MSM, Men Who Have Sex with Men in Jakarta, Indonesia. And then you've also shared a translated ethnographic interview, an essay with activists, and is it Ruli Malai? Have I pronounced that correctly?
Yeah, Ruli Malai.
Okay. Yeah. On impacts of SARS-CoV-2 on one transgender community in Indonesia. So I cannot wait to hear your thoughts and perspectives on this work that you've been doing over the course of a global pandemic. I wonder if we could just first go around the room, and if you could just please tell us where you are in the world and what your organization is, or who you're representing, just to start for our audience, and then I want to dig into some of the literature, or the gaps in the literature that prompted this research. So please.
Brilliant. Thank you so much. Shall I start? I'll start.
Yeah, absolutely.
Thank you so much, Rachel, and thanks to Evan for the invitation. I really appreciate it. So I'm Ben Hegarty. I'm a Mackenzie Fellow at the University of Melbourne, and I'm speaking to you from Melbourne, Australia.
Welcome. Amalia, where
I can go next.
Okay.
Yeah, go ahead.
I'm Amalia Handayani. People call me Amalia. I'm based in Jakarta, Indonesia. And I'm one of the researchers in PPH Atmajaya University. So PPH is like a research center, like AIDS research center.
Okay. Thank you so much for being here. Sandeep.
Yeah, hi everyone. This is Sandeep. I'm from Jakarta. I'm currently in Jakarta. I'm a physician and I work at UNFPA, the Sexual and Reproductive Health Agency of the UN. And I work with governments and NGO on HIV and youth and adolescent sexual and reproductive health.
Wonderful. Thank you all so much for being here. And I really can't wait to hear your perspectives on this, this new research. So I wonder if you could maybe start by telling us a little about the gap in the literature that prompted this. Maybe it didn't prompt this research, but you're framing it in that first article that you shared with us. And comment a little bit on the research methods that you decided to utilize amidst outbreak. Why outreach workers and activists? What prompted the particular framing of this focus for you all?
Yeah, great question. Shall I go ahead, or Sandeep, do you want to start? You want me?
Maybe I can start, and then Ben, you can. So the idea was, it was not basic. So I didn't personally. Maybe Ben thought of it in an academic sense, but I didn't think of it as a knowledge gap in an academic sense, in the sense that there was a gap in the information of community health workers or outreach workers and such. But what I thought was the way outreach workers were framed in the national policy and implementation landscape of HIV in Indonesia, which is very donor oriented and the way it's funded mostly through donors, right? So the way it was conceptualized was as with a lot of assumptions, that they only do certain things, that they can do all their activities online. And these assumptions were even more heightened during the COVID pandemic. So there were these assertions like, oh, we could do everything online and so on. And whereas we have relationships with NGOs that are too afraid to speak up what are their lived experience. So they are only concerned in giving the targets and writing the reports back to the donors. And that's the tension we saw. And we saw that maybe perhaps we could be the mediator and the neutral party or the politically neutral party in that debate to inform what is actually happening in the field. And inform them and ask and question some of the assumptions that outreach workers they don't also treat patients, they don't also work as health workers, they are not also at risk, they don't need PPE, things like that. And what we saw was they need PPE, they were also in hospitals, they were also taking care, they also had mental health concerns and so on. And so I personally saw it as a very pragmatic research undertaking, that we need to document all of this so that we can share and question these assumptions in not only an academic sense, but mostly in a very programmatic sense. And that's where I question the research. But Ben and Amalia maybe has a different way of seeing it. But for me, it was really programmatic. To question the assumptions made by programmers, which were even heightened during the COVID pandemic.
Yeah.
Then maybe you have.
Shall I jump in? So that's absolutely right. There was a certain kind of urgency and responsiveness in the work that was seeking to really draw out some of the narrative accounts and experiences of HIV outreach workers. So for those who are not familiar with this landscape, just to clarify what the role of an outreach worker or an HIV outreach program looks like in a place like Indonesia. So, and Sandeep can probably fill in some of this information a little bit more. But in the Indonesian context, you have a backdrop of, I guess, a very complicated landscape for the provision of HIV testing and treatment and care. So on the one hand, you've got the kind of emergence of an international policy shift. So international donors who have, for the most part, supported a range of different programs, including the provision of antiretroviral medication, which is still funded in part by international donors. So there's kind of that component of the response to HIV. So, on the one hand, the international donors who supply funding for antiretrovirals, and along with that, and increasingly it's seen as kind of secondary or derivative to that, is the work of community-based programs, which comprise outreach. So traditionally, and again, Sandeep can, working in this space, can speak more to this question, but traditionally those programs are seen as the provision of information. So in a rather, provision of information on the one hand, so safe sex messages, what else, condoms and lubricant, where they're available, although there are really important questions about the availability of condoms and lubricant to HIV outreach workers throughout the pandemic. But also increasingly in an age of increased access to HIV medication, antiretroviral drugs, a context which is, the dominant policy narrative is a cascade of care, which as we wrote about or framed the study in relation to a cascade of care. These outreach workers are often seen as information gatherers, data workers of a sort, who kind of go out into the field and they are required to meet, targets in terms, generally understood in terms of the three kind of dominant checkpoints or milestones, testing, retained in testing and suppressed viral load. So that kind of is like a drumbeat. I think one researcher, Stephen Moldrum, has called it, of HIV international HIV policy. So you sort of see a kind of move, I guess, of outreach workers being positioned as these almost kind of bureaucratic or data workers in programmatic, in their terms of their programmatic definitions, which has neglected, I guess, the ways in which they perform and engage in vital and life-sustaining forms of care work. So I guess that's the kind of both historical, but also I guess the conceptual or theoretical backdrop to the paper. I can speak a little bit more about how we came to. So, I might just add that, this research was like many aspects of the pandemic, accidental or contingent. So Sandeep and Musgambit, who's our fourth co-author, who's not with us today, joined me in Melbourne in early 2020, if you can believe, managed to travel to Melbourne and participate in a workshop on gender, sexuality and health. And in the course of that discussion, we started to kind of formulate a plan for I guess, collaborative ethnographic work, at the intersection of public health and anthropology, which is something that Sandeep and I have been engaged with for some time. So Sandeep and I know one another, known one another for some years. And so what we did was try to formulate a way in which we might get at some of the experiences of doing HIV outreach work, which is that, on the one hand, programmatically is kind of defined on almost technocratic terms. But in reality, as we know, and through our earlier ethnographic work on both HIV outreach work, but also male sex work and sex workers in Jakarta, who comprise an important group who are the focus of HIV outreach work, we kind of formulated this project to follow along the experiences of the pandemic from its, from really the moment that it was declared a national health emergency in Indonesia. From memory, by the time our research got going, I think it was it April or May, Amalia, of 2020?
It was started in April.
Yeah, exactly, April or May, and more or less we followed through until September in a more intensive kind of mode. Of course, knowing that the time and availability of outreach workers is incredibly limited. Of course, then the temporal dynamic of the pandemic has meant that the following year, in fact, 2021, was a year of real tragedy and hardship for the participants in our study and our friends and collaborators. So very sadly, one of whom passed away. One of our participants passed away from complications related to COVID. And
I'm so sorry, folks. I'm so sorry you lost a participant of it.
Yeah, thank you. And almost all of the HIV outreach workers employed by the organization contracted COVID across that time. And this was in the context of the wave in July. Was it July, August? Yeah, July, August of this year, of 2021. That we responded to in the various ways that we could, but also illustrated, the ongoing neglect, I guess, in policy and programs to the concrete practices of care and essential work that HIV outreach workers do. So, you had things like this, as Sandeep mentioned, this assumption that outreach workers could conduct their work online, right? As though the provision of information or care is able to be delivered in that way. But also, as the title of, and I would just, before I pass on to Amalia to talk a bit more about the methods that we use, which were, a really enjoyable part of this. And I think, the ethnographic component of this is, and our relationship is a very kind of, to me at least, a very nice component of this research, is that the process of data collection, analysis, and writing has always all been conducted together across a period of time. But in any case, that there's a certain neglect or a lack of willingness to acknowledge the extent of the work that outreach workers do. So we really observed that, and that manifested in various things like inadequate access to PPE, for example. Given that, you know, in this ideal world where outreach workers are supposedly able to entirely undertake their work online, they wouldn't be attending healthcare centers, for example, primary healthcare centers or HIV testing sites. But of course they were and they are. And so to access, you know, adequate PPE, to access adequate testing in particular. So testing hasn't been widely available. Rather, it's a rather costly endeavor. So, you know, running at about $20, between $10 and $20 a test at the time that we were following in July of this year. So I mean, you know, really what we wanted to attend to in this essay is how, I guess, pernicious or how problematic this kind of framing of outreach work is in relation to a preoccupation with targets, and hence why the article is titled "Chasing Targets in a Pandemic," which really doesn't only kind of shape the work that, you know, outreach workers do in terms of the fact that they have to meet targets, but the cascade of care as a dominant model, kind of driven by, you know, pharmaceutical and biomedical models of how that HIV pandemic can be addressed, is at every level shaped by these really what are kind of a preoccupation with I guess financialized models of risk and behavior, which ultimately really sit at a very jarring odds with the practice of living with HIV in Indonesia.
Thank you both. I wonder, Amalia, did you want to maybe step in and talk a little bit about the methods component, and then maybe we can swing back to the question of the cascade of care and flesh that out a little bit more for readers at home.
So we have a few data collection method. The first one is interview. So we interview 10 outreach workers, and they are coming from 2 different international donor programs. So we can see the difference. And we also have an interview with 4 NGO staff to see how they try to arrange this data collection regarding the HIV program care during the pandemic. And we also have like 6 interviews with the health workers to see what happened in the healthcare facilities. And it's not only that, but we also have a forum group discussion with outreach workers. So we make them as 2 different groups, but we also did it in like 4 different focus groups. So we will know how it has been changed their situation within during the week as well. And we also have another data collection method, which is the outreach workers send video diaries. They do not have to send it like every day, but they send it like once in a week, but it's going on for 4 weeks. So it really helped us to see how the policy has been changed so fast and how it impacts their role as an outreach worker during the 4 week as well. And then we also have a really short survey to the outreach workers just to see the difference before the pandemic and also during the pandemic. So there are 4 methods that we have been used when we're doing this research.
Thanks, Amalia. Yeah, I was really struck by this expanse of mixed methods. I thought this was really fascinating just to read about that component, and was really struck by the use of the video diaries as well. I just can't wait to, I imagine that there's more work that's going to come out of that, because it just seems like such a fascinating and intelligent way to be able to follow healthcare workers beyond the context of, say, focus group dynamics and things like that. So interested in the methods that you all used. I wonder if we could hear from you a little bit more about the cascade of care continuum. I've heard a number of, Ben, you hit on a couple of different themes already, Sandeep. You've sort of outlined, but I wonder for people who are unfamiliar with it, what are some of the kind of big markers of this sort of, can we say, trend shift, historical shift? What is this about? Is this really about like the tension between funding, local level, community level, and international level dynamics? What are some of the major themes in this historical shift?
Sandeep, do you want to start?
So basically the cascade of care first. So the idea is that there's this hidden population that needs to be identified, and they need to be informed of people need to be informed of their risk-taking behaviors. And when they understand the risk, they can be brought into a health facility or a mobile testing or anywhere people can get tested. And they can get tested rationally. They can get tested, and if they are positive, so the first cascade is getting people to understand their risk and then getting tested. And then once they get tested, if they are positive, they have to start treatment, right? Start ARV treatment. They start ARV treatment. That's the second cascade. And once they are on ARV treatment, they have to continue ARV treatment until their viral load is suppressed, which is the third cascade. So this is how it's understood, as this individual who understands the risk, has an increased risk perception. Rationally, if they have risk, they have to take tests. And rationally, if they take, if they are positive, they will continue their medication, and they will take medication until they're virally suppressed, and they will continue taking medication, so on and so on. So that's how the HIV program is designed. And the flaw is, again, why is it designed this way? Of course, it has a historical, sense. It's also part of this very neoliberal idea in health, right? That it's an individual responsibility. People are rational actors. They just need to understand their risk perception. And this is codified in many different programs. And in HIV, it's codified as this cascade of care. In other programs, for instance, it's like telling mothers who are to how to breastfeed their children or things like that, right? And that's this dominant view in global health, right? We just have to educate, understand risk, test, get treatment, right? It's changing individual behaviors. But of course, this dominant view is being translated in the Indonesian context in various ways. And it includes, in my opinion, including a very kind of a moralizing way of understanding the cascade too. So if you are at risk and you don't rationally test, that means you are wrong. How can you are at risk and you don't test? If you're HIV positive and you don't take treatment, how can you not take treatment? If you are on treatment and you are lost to follow up, that means you're a moral failure and things. So there's a very moralizing component in the way that big global paradigm is translated in program across its many dimensions, through training, through the way data is collected, to the way these outreach workers are positioned in program, right? But of course, in a setting like emergency, this even before emergency, we knew, and that's a very, very long experience of actually helping people go through and navigate a system, that this is a complete, this is not the case at all, right? Of how it works. And in fact, the moralizing tone of HIV program, in my opinion, actually makes things worse than help at all, in any sense, right? The training that outreach workers get actually makes it worse than help at all. And we've been trying to say, let's just document what an outreach worker actually does. And in the same time, we have this dominant paradigm in these these donor recipient NGOs, these national NGOs, and the UN organizations. We have this dominant view of how this cascade goes. But also, even pre-pandemic, people who are in the field know that there were forms of care delivered in the field by these outreach workers that they could do, right? Like they could get ID cards, they could get people emergency help, they could bring people to services when they were very sick, they could find help. They scavenged all their resources, used all their networks, draw on all the relationships they have to support the person before them who was probably in severe case or an emergency. And we knew that form of care was also happening at the same time. But this dominant narrative was getting more intensive. And in COVID, this dominant cascade narrative was even more intensified with this. To me, it's this sudden idea that everyone is rational, that yeah, it's okay if they know, they just need to give information. Again, that risk perception, from risk perception to testing and so on. Oh, we can do testing home kits. That was the discussion among policymakers, not really how to link people to care when they need it, how to address some of the challenges, including mental health challenges of the workers itself. And so when we put it in cascade care, the problem is that these outreach workers are not considered essential part of the health system. So their job is just to provide information on risk perception. And ideally, if their person thinks that they're at risk, they would go to the health system and get tested and get treatment. And people were talking about how to adapt things in the health system, but we knew that in a setting where HIV is highly stigmatized, there's this really attacks in public spaces for LGBT groups, for MSM groups, and different laws being used. We knew that these outreach workers were actually the backbone of the services, and somehow that was not really translated in policy scheme. And to me, this cascade of care is the big problem, and it was worst. It was intensified, especially that when they tried to translate this cascade of care to something online during COVID, when they did this translation of this cascade, this assumption of this individual person with risk perception and so on, it intensified the assumptions that, oh, okay, someone would just get information online and they will act on it, right? So that's, I think, the big problem with the cascade of care. And I think it's a problem of global health, and it has a specific manifestation in Indonesia, and in the HIV program in Indonesia. But I think it speaks to most global health programs that focuses on educating mothers or things like that in different ways. So I think it's one of the manifestation of a global health paradigm, which is, of course, the same thing happened in colonial times and so on, but it's a manifestation of this paradigm in a very specific, highly moralized setting surrounding HIV, with forms of care, which then the burden lies in these outreach workers to navigate this paradigm and the realities. And so we thought that they play such a crucial role, and they should be the highlight of our study, and their voices should be the main informers of policy, because they bridge between the two. We could obviously speak to MSM who have HIV and speak about their experiences, but the people who would have concrete steps on what to do in the very practical way would be these outreach workers, because they bridge between the paradigm, which is the dominant way their programs is funded, and the realities. And if you want to work and change the structures, I think the outreach workers have a lot of knowledge, and this is part of gathering more their knowledge. And the way it's written up is also what they do, how they see themselves doing their work, and things like that. And I think this is a form of knowledge that actually has been used in the new. So there's a new design of outreach program in the new Global Fund program, and it has been used several times in ways to advocate for their knowledge and what they know and how to bridge in reality to get pragmatic steps of what to do, because they know best what to do. Yeah.
Thank you for that, Sandeep. I think that is wildly helpful for folks who don't know much about these broader tensions in the dynamics of funding and care that you're outlining. I was wondering if we could maybe extend on some of those ideas a little bit more. I personally live with an emergency healthcare practitioner and was struck by some of the descriptions that are provided in this in both of these pieces, but especially this first piece on chasing targets of outreach workers who are helping to navigate conditions in clinics amidst COVID, and that really rang true to the devastation in many care facilities. People, just things that we're hearing, I think, all over the world, and certainly in our household, we hear every day, patients being rerouted away from certain clinics or hospitals, certain wards maybe entirely being shut down, or being discouraged to present without, having explicit clearances and things like that. But it also reminded me of a piece that came out pretty recently by science writer Ed Yong. And he was reflecting on, what it might take to imagine, SARS-CoV-2 as endemic in some future. And in many ways, he's kind of, in doing that, pushing back a little on especially the US's sort of it's a sort of hyper techno-scientific reliance. Something that in terms of pandemic management in other nations, we see maybe a more reliance on other, processes or tactics, maybe perhaps more administrative initiatives or tracing, for instance. And on page 9, you wrote, quote, I'll read the quote out loud to everybody. Given their significant experience addressing misinformation about HIV, outreach workers reflected on their role providing information about COVID-19 on parallel terms. And I just wonder, if you could comment a little bit more on that, that situation, on that particular quotation, and what additional workloads and points of reference beyond, Sandeep, what you've already outlined for us here of the kind of misunderstanding and misinformation, a lack of awareness about what outreach workers are actually doing in the day-to-day. I mean, can you say a little bit more about the additional workloads and points of reference and care work that you're seeing outreach workers doing now in a world, amidst a pandemic?
Amalia, do you want to?
Okay.
Yeah, go ahead.
So from what we listen to their stories every day during the data collection, they mention it's really clear that they are in the first, how do you say it? In the first gate of the information, because they provide main information regarding not only HIV but also the public health information. So since they are in the first contact with the population, with the community, so they have been asked so many questions regarding the COVID-19 as well. So they are expected to answer those questions. So it's not only the questions regarding HIV that they have been trained for, but they also have been asked about the COVID situation. But unfortunately, they are not trained to answer those questions. So they need to try to collect all information by themselves, and also to filter the information that they receive, whether it's hoax, whether it's real, from which source they need to find that information. So it's one of the workload they have been added on their task during the pandemic. But also during the pandemic, the clinics and the hospital working in a different way, because they have a different schedule. They couldn't, how do you say it? They have like a limited patients that can come and then can go through the clinic. So they need to find which clinic that can be visited by the community. So it is also one of their additional work.
Amal has dropped out.
Amal is, yeah.
Amalia, I
Frozen.
think, yeah, maybe
Frozen,
you
yeah.
froze. Let me see if I can try to.
That's right. I mean, just to maybe continue if Amalia has dropped out. But that's right, kind of. And also, I mean, you know, acknowledging these, I think the comparison. Oh no, Amalia, do you want to?
Welcome back. Sorry, you froze there for a moment.
Sorry, I don't know where I left, but the last time I talk about how they need to refer the clinic that's still open or still provide the service for the patients or for the clients. And then the third things, it's about how they also need to find service, the health facilities that also provide, how do you say it? Because many patients or clients couldn't afford the service. So they need to find like a free service or like a really accessible for the community as well. So there are three things, but also there are also another administrative workload that have been added. So since they couldn't go to the work because they are suggested to work from home, which is another challenge for them as well. So they also need to provide the report through the digital, through the form, online form. And it is new for them, so they need to learn about it as well. And at the same time, it hasn't been trained, and it doesn't mean it's not necessarily change the report that
I think she's stuck again.
Yeah, we lost you again, Amelia. Maybe try, if you can hear me, maybe try without your video.
Yeah.
That might help.
I mean, I think so. The fact that you had this additional layer of kind of bureaucratic data collection during the pandemic related to HIV. To my knowledge, I don't think HIV outreach workers were tasked to collect information about COVID. To my knowledge, but rather additional information about the HIV epidemic, both online, but then continue to kind of, you know, reflecting a kind of fetishization of paper bureaucracy. You know, it could still write out reports, right? Manual reports that had to be couriered then to the office where kind of a skeleton staff could deal with these reports. Hi, Emma. That's all right. Did you want to try without your video to?
Okay.
If it keeps maybe it keeps
it helps.
dropping out. Maybe, yeah. Either way, but I just wanted to jump in as well to, you know, into the way in which we've tried to conceptualize HIV outreach work. I mean, builds on, you know, this kind of, I guess, long ethnographic engagement that Sandeep and I have had with I guess the field of HIV more broadly, but in relation to mental health with men, MSM communities, and transgender communities, or transgender communities of transgender women in Jogja, which is the context in which Sandeep and I met in 2014. You know, working at this incredible shelter for people living with HIV, run by a very charismatic transgender woman leader, Mummy Finolia, and that's the account. So Mummy Ruli, who's the author of that translated ethnographic interview, provided the second article provided for this group today, works with the Kebaya, the shelter for people living with HIV, but really kind of our relationship to, I guess, the experience of conducting HIV care work, across broad domains. So may not necessarily be have been strictly programmatically defined as HIV outreach work, but also things like buddy programs, kind of where upon receiving a positive diagnosis for HIV, that you're then paired with someone else living with HIV or another member of your community, sort of that context, but also kind of broad volunteer work. But since that time, Sandeep and I have observed the various ways in which relations are really central to the vital work of engaging and working through the epidemic, which has disproportionately affected the communities that we work with, MSM and transgender women, in a climate where you have had an extent to, I don't want to necessarily kind of what's the word, like fetishize forms of homophobia and transphobia as unique to the Indonesian context, but that have seen certain specifically historically contextual forms of hostility towards communities of trans women and to MSM. So in that context, we kind of have worked, on the one hand, we've got the trans communities that we've been working with. On the other, we kind of commenced this ethnographic work with HIV outreach workers, where we have always tried to attend to relations between HIV outreach workers and other forms of really national healthcare systems or national healthcare infrastructures. Even though they're often kind of divided out or passed out as very distinct kinds of things, they're often occupying the same spaces and working through the same spaces with the same patients. So, one of the most revealing anecdotes, I guess, from early research that Sandeep and I, and this was in person, this was since 2017, we've been doing this research really more intensively with HIV outreach workers and MSM in Jakarta. But the fact that HIV outreach workers would see their kind of bodily habitus of non-dec, what is called non-dec, or like a kind of queer among male body people in particular, a kind of queer performance, right? Or a kind of, a feminine performance, and that they would see that non-dec as attractive to healthcare workers, right? Something that could entertain and therefore enjoin healthcare workers who they saw as largely straight into their community and into the kinds of care that they were seeking to provide. So I thought that was kind of a lovely way in which, just one small story, but the way in which outreach workers would say, oh yeah, if we're non-dec in a particular way to a particular audience, we can kind of attract or enjoin these healthcare workers into forms of friendship that will better serve kind of patients, right? Also that we would act as representatives of our community, and work to navigate through these kind of really complicated, often what are complicated on many terms, bureaucratically, socially, politically, and otherwise, but that one bodily form of performance, non-dec acting as a kind of way in, and a kind of to enjoin those people into a relation, and that relation as being kind of neglected, as Sandeep said, within these kind of rationalizing impulses of dominant models of global health.
Yeah, if I may add, just the relationship between COVID and HIV. So what was happening amongst everybody was that there was just so much information and we didn't know. And now, at least now in this moment that we've lived through COVID 2 years, we know where tests are, but at that moment in the early start and now, you need to have the relationship with the health worker or with the health authorities to really know what concrete steps you can do to navigate to get access to COVID testing. So it was not that it was like an added work that they did not naturally. They did it naturally because they had built a relationship with health workers, and this was a kind of a natural way in which at that time you needed that kind of drawing on that relationship to find, where can you get actually free tests, right? Okay, you can get free tests with this indication. It was changing all the time, which the expansion of tests and so on. whether antigen is enough to go to the hospital or PCR, things like that, right? And they could draw on the relationship with the health providers to provide this very specific, very form of care. And this relationship has been built from HIV, right? And so it was not out of like random, like programmatic, like thought that they were providing COVID information, but it was just because they had that relationship and they wanted to help the people they serve, right? So it was kind of in a very natural sense, I would say, that they provided COVID information. And you know, there's this debate amongst health providers that, oh, they should be specific for HIV, they should be specific for COVID, and you know, even amongst Global Fund, whether Global Fund should fund COVID or just fund HIV, TB, and malaria, which is the biggest funding, and PEPFAR, for instance, the President's Relief Fund for HIV. Should they just fund HIV or should they fund COVID or things like that, right? And you know, when it comes to the field, these questions, you know, get dissolved automatically, right? And you know, and they, because you build on those relationships, and if you really acknowledge that, and that's what I saw, how I saw the relationship between COVID. And at that time, what is so fascinating to me, and seeing it now, yeah, at that time was that COVID testing was so confusing. It was just like HIV. It was just like, how do you get PEP? It was like this privileged information you get from this network, and you to get free tests, you go here. It was just, to me, it was HIV. What is sad as I reflect at this moment when I speak to you now is that COVID has, you know, testing for COVID has become normalized. It is now available in Indonesia quite everywhere. Some are free, some are not, where to get free, and that information is there. But unfortunately, HIV testing still remains this like this elusive way which you get this network, and oh, from this network I get testing. And so that's the similarity I saw in the early start of the pandemic. And obviously, when you have this elusive, like, oh, where to get test this disease, where to do that, you ask the same person. And it's I think out of a natural way that they provided COVID support. And they did provide not only information, they provided information, access to testing. They drew on the same kind of networks they draw on to get testing, to get even HIV, COVID isolation centers where people would not isolation centers, and you know, people, you know, they knew how to get access to that COVID centralized shelters where, you know, you get free treatment for 14 days, you get food, you get what from the COVID centralized shelter. And you know, I think this is a natural consequence of working intimately with the health system. And you know, when you know, they are not the only ones providing COVID information. Other programs like TB outreach workers, the village worker, the maternal care worker, they would also provide COVID information because they had that privileged connection to draw on from the district health offices. So that's which, so they helped their neighbors, not even, so they were not even helping MSM, but they helped their neighbors too. Because of COVID affecting everyone, right? So they help their neighbors, they help the elderly, because they had that relationship.
Yeah, this was something that really stuck out to me about both of the pieces, and including your translated interview for TSQ. You know, maybe reflecting a bit more on this question of solidarity that both of the pieces, you know, raised for readers today. In the second piece that you shared, there were, I mean, even these dynamics of mutual aid with regards to just access to food or, you know, or housing. So, and then in the first piece, you know, you're really pointing out some of the, you know, many of these things, Sandeep, that you've outlined here just now about the different kinds of care and networks of care and the, you know, the webs of those networks that extend far beyond the kind of presumption of what outreach workers are doing. So this was really striking to me across both of the pieces. was this sort of all of the work and all of the care work, especially, that is not encapsulated in this this sort of broader, framing that falls far short of what people are actually doing. And what I'm looking for the quote. I don't know if I have it in my notes now, but I mean, what you called, especially with regards to the second piece, as really vital knowledge bases from transgender communities and trans activists who are already working and doing this broader outreach work as well. That this becomes vital for a variety of different reasons. So this was something that was super striking to me across both of these pieces. I wonder though if you could say a bit more. We could just circle back to the title of the first piece. Then Ben, I know you mentioned it, chasing targets, but I wonder if you could just say a little bit more then about this. And maybe we can ping pong back to that idea of the hyper emphasis on meeting targets. What is that, why is that falling short then, given what Sandeep has outlined here and given what these two pieces really reveal about the kinds of networks of care and work that's actually happening?
Yeah, I mean, this is something we've observed, kind of emerge, I guess, over time. As you say, this context where you have basically techno, almost techno utopian, right, or technical kind of convergence of technical and bureaucratic forms as the authority that will kind of solve the problem at hand. I think has given rise to this context where effectively the only way in which something like the HIV epidemic can be managed is through these forms of targets, and the targets are really designed in many ways to, I guess, be punitive, really and these targets are felt all the way down the ladder. So on the one hand, you've got kind of national level targets. There's an international target which is 90-90-90. So 90% of people who are at risk testing for HIV, 90% of people who test positive for HIV are then enrolled in treatment, and that then 90% of those people who are enrolled in treatment have a suppressed viral load. That's the kind of, and therefore are unlikely or not able to transmit HIV on. So this idea that then you're undetectable and therefore you have an undetectable viral load, and therefore you can't transmit the virus to anyone else, and therefore treatment is conceived of as prevention. So those two things kind of loop kind of into one another. Of course, for all of the kind of complicated reasons and kind of problems of structural access, problems of testing in the Indonesian context, in that knowledge about HIV testing and knowledge about HIV is incredibly kind of opaque, right, and difficult to come by. There are still kind of there's this certain haunting quality to the figure of the person living with HIV, which is how people, Tom Belstoff, the anthropologist, has described the figure of the person living with HIV in Indigenous society as kind of almost like a kind of figure who's an absent presence within Indonesian society for all kinds of historical and cultural reasons. But for those reasons, these targets don't necessarily can never necessarily drive the kinds of, or reveal the ways in which access to HIV care, HIV testing, but also HIV treatment, where it's required, can take place or unfold. So that's the kind of, I guess, the kind of broader cultural context in which, you have this kind of international targets on the one hand, but kind of shaped by these kind of, I guess, national cultural dynamics on the other.
So we're at 10 a.m. my time. But I'm wondering, I still have a couple of questions. I'm wondering if you would mind sticking around for another 10 minutes or so, if you have
Yeah.
that time.
Yeah, go ahead.
I just
Okay.
wanted to add one thing though, just one thing that is important to think about when we think about it is that who funded the community-based activities, the food and so on. And for me personally, I felt very betrayed by Global Health, where donors were not wanting to fund food, PPE, testing, and so on. But the ones funding were religious, mostly religious institutions. We didn't have a good idea yet who at the time when we wrote the reflection, but in the most recent June, August surge of COVID, the people who provided food, who provided access to food, to shelter, to money in different ways was, collective money, which, people sent the collective money, and also religious groups like NU, Gus Durian Network, Catholic priests, the nuns, all of them supported by giving funding to the food and for food and so many other things. So for me, that was a very betrayal for me of Global Health, where actually HIV funding was kind of called for by activists, not by experts, but by activists, by ACT-UP, by people who in South Africa, in different parts, who fought for these fundings, who fought for PEPFAR, and they didn't deliver during the pandemic. I think that's an important part to mention, that the funding and support was mostly from what we wouldn't consider as global health or health in any sense, but it was very community pooling of funds and religious groups too, especially for trans.
I think that's such an important point. We were really struck. So, this article was written and published before the surge in June, but that June through August of this year, which was just so kind of, frightening and kind of and tragic in so many ways, given both the kind of the amount of time between the onset of the pandemic and the fact that this surge took place, and that our HIV outreach workers, among many others, but were exposed in the way that they were, without adequate access to to basic things like testing or PPE. So Sandeep and I were involved in mental health care. I think this was the aspect that Sandeep really was incredibly important. But those sessions that we ran, Sandeep. So
right. I mean, even one outreach worker was so overwhelmed, he died of suicide. So things, it's so bad. But when you look at the policy level, none of these discussions was happening. So to me, a lot of it was kind of a failure of how global health institutions, which are very colonial, could manage, right? And to me, what was very sad was that HIV funding was dreamt of and was fought for as something that would answer all these questions, right? That would answer these needs of support. But I was so shocked, for instance, when the first time we asked about COVID, when I asked these outreach workers, did you? I said, I'm going to call a friend of mine from the Puskesmas to answer all your COVID questions. And they were just asking simple questions like, can you reuse a mask? I washed my mask with this, things like that. And even that kind of support was not received from donors at all. And to me, that's such a betrayal of global health. And that's where you can see it more heightened in crisis. I'm sure patients with HIV see the betrayal every day. And for me, I could see it most in the crisis, when there was no responsibility at all. When 20 people got COVID, no responsibility at all from donors to provide testing. They didn't even ask the condition. So this to me was just so unbelievably tragic. I hope we learn for the better. and you know, not, I hope we don't face it again, but it's likely that we will face this every time we have a crisis. And I'm sure that people with HIV face this betrayal every day. So I just wanted to add that point too.
Yeah, so important. And you're really, with these last points, you're really, I think, hitting on two of my questions, which really had to do with, you know, sort of thinking about, you know, lessons from HIV for a COVID world, you know, historically, epidemiologically, socially, you know, culturally, but also, you know, what do you want kind of moving forward from funders? I was so struck by, I'd like to actually read it out loud for our viewers and listeners, that those last few lines of the second piece, you know, end with some really important kind of calls to action. From the interview, you know, we clearly need better access to work and other economic opportunities in which we face stigma and discrimination. We hope that our response to this emergency can be a clarion call issued to the government, which can catalyze support for WRIA, I hope I'm saying that correctly, to improve themselves. During this public health emergency, we have shown that we have skills that are useful to Indonesian society, and we have demonstrated our solidarity with the broader society, and from them we seek acceptance in return. You know, a very clear call for action and change. And Sandeep, you yourself outlined it a few important points just now about, you know, what do you want to see moving forward from funders, you know, in light of some of these pointed feelings of betrayal about you know, the ongoing work. Just open, you know, if anybody has any final thoughts, I'll leave it open. You've touched on so much.
But for me, I think just to acknowledge, you know, some of the work that outreach workers, and engage them, because they know more than any of us on how to navigate care, and they know the dominant paradigm, they know the importance of the programs, but they also know what can happen, what cannot happen. And so I think if their voices were just elevated and we didn't, you know, to me, the problem is because the NGOs are so reliant on foreign donor funds, on HIV service funds. There is just no other fund to sustain an NGO enough for them to have power to speak back and you know, be against some of the practices. They're so reliant for their livelihood on donor funds. And to me, you know, it's so against what is public health knowledge, but just to give money for institutions, for NGOs to survive without expectation, so that they can actually truly be advocates and not just, you know, try to deliver what donor wants, right? So you know, an earmarked money for NGOs to comment on. And you know, I have several activists have spoken about this in Indonesia, that there's just such a big reliance on HIV service delivery for the sustenance of the NGO that they can't really comment so much. They just have to deliver, because otherwise the NGO won't sustain. So to me, one of the biggest concrete step would be to earmark funds and to acknowledge the unpaid work, to pay it and earmark funds for their sustenance, so that they can actually advocate and function as they are meant to, not just in documents. Oh, we supported how many CSOs and so on. That would be one concrete step for me.
Yeah, I think it reminds me of, you know, you asked about targets before, but of course one, you know, and one implication of targets is, and this is partially, of course, what they're designed to do, is that they make organizations, you know, they place them in a very dependent relationship to donors, and one in which they fear losing their funding, and where you have kind of, you know, the leaders of these organizations, and who are often community leaders themselves, conducting, you know, really important forms of advocacy in their communities. You have them in a position where they're incredibly stressed and incredibly worried about the survival of their organization. And I think that's a really lamentable consequence of this present system.
So one final question for everybody. I mean, you know, as you know, in conducting research, you always have things that you and directions you can't take, and things that you that you have remaining. I mean, I'm just wondering where you might be going next with this work. What do you foresee? Or questions, you know, driving questions that might be with you still.
Maybe Ben can answer.
That's a great question. I mean, I feel like there's so many, and you know, like everybody, you know, we're kind of I'm pulled between, you know, lots of different projects. This one's very, very important to me. What I'd like to do is, I mean, kind of keep following, you know, as Sandeep said, this has been, you know, a kind of a great disappointment, you know, from the point of view of donors, but for us to be able to continue kind of this ethnographic work and to keep up the relationships with HIV outreach workers and with the trans community who Sandeep and I, you know, both work closely with, to really look at the intersections of the HIV epidemic and the role that kind of community advocates have played, but also these kind of broader shaping structures have played, you know, so the emergence, for example, of the cascade of care or antiretroviral therapy as these dominant technologies, the ways that they're taken up and worked on and with by communities. I'd love to kind of, you know, extend a little bit more into their, you know, their implications or intersections with COVID, as COVID continues to kind of be something that we're living with in the world.
Well, thank you very much, you three, for zooming in with us today and talking about this profoundly important work of yours. I really appreciate your time and the extra minutes to your schedules to continue to delve a little bit deeper into these really great pieces. For people at home, if you've got time to join us next week, December 13th, Monday, December 13th, we've got University of Chicago anthropologist, Dr. Teresa Montoya, and also cancer epidemiologist, Dr. Mark Aaron Emerson, who is at the NC, the North Carolina Chapel Hill Center for American Indian Health. They're going to be joining us to talk about their recent publication on pandemic impacts in the Navajo Nation. Thanks again to Ben, Sandeep, and Amalia for joining us from multiple sites around the world and speaking about these incredible pieces. I hope you all have time to sit with these pieces and think through them as well from home. And thanks everybody for joining us today. Hope to see you again soon.
Thank you, Rachel.
Thank you very much.